Coming up today, weak hands, trouble with speech, critical thinking, or memory. All of these are side effects of a stroke that create daily challenges for stroke survivors. We'll introduce you to a new way to rewire the brain and build back your confidence. Good morning, I'm Jessica Lovell, and welcome to the Morning Medical Update. Every 40 seconds, someone in the United States has a stroke. The CDC reports nearly 90% of those strokes leave patients with emotional, behavioral, or cognitive challenge, as well as sometimes weak hands and arms. Today, we're going to show you a special implant that boosts the power of rehab. But first, let's get to our morning rounds. The FDA has approved a new CAR T-cell therapy to treat leukemia. This is now the seventh CAR T therapy to get FDA approval, and we are learning more about it this morning from Dr. Joseph McGurk. He is the Cancer Center's Division Director of Hematologic Malignancies and Cellular Therapeutics. And of course, Doc, we have talked a lot in the past with you about CAR T-cell therapy. But before we discuss this newly approved therapy, just remind us what CAR T therapy is and, of course, how it's changed cancer care.
You bet. Good morning, Jess. It's good to be here. And CAR T-cell therapy leverages our understanding of how the immune system, specifically cells called T cells, not only fight infection, but also can prevent cancer, or if a cancer develops, eradicate that cancer. And things go wrong when patients have cancers that progress. Our T cells have let us down. And so this therapy, CAR T-cell, involves taking patients' T cells out of their blood to the laboratory, genetically rewiring them to again recognize the cancer cells, expanding them into hundreds of millions of cells, and infusing them like a blood transfusion back into the patient. They sweep around the body, identify the cancer cells, attach to them, punch a hole in them, and release proteins that go through and chop up their chromosomes, their DNA, and kill the cell. And this has been really a paradigm shift for patients with a number of different types of blood cancers, lymphomas, multiple myeloma, and acute lymphoblastic leukemia.
This has been so interesting to watch this develop, Dr. McGurk, over the years, and to hear you talk with us about it. This newly approved drug, and you're going to have to help me with the name. I think it's called Aucatzyl.
That's correct.
Yes.
Aucatzyl.
Yeah.
You got
it. Good. So this is the third CAR T to specifically treat leukemia. How does this CAR T differ from the other two that have treated leukemia in the past?
Absolutely. One of those CAR T cells, called Rewire, is used to treat children, adolescents, and young adults up to 25. Aucatzyl is for 18 years of age and greater into adulthood. And there's another, a third one called brexacaptogene, Tecartus, to treat adults as well. There are a lot of toxicities associated with CAR T-cell therapy. When they attack cells that have the flu virus in them, they make us feel terrible. When they attack cancer cells, and there are billions of them when patients have cancers, they cause the flu times 3 or 5. In addition, the T cells can become exhausted by being overstimulated by too many cancer cells. We don't want that to happen. And so Aucatzyl tackles this problem with a strategy that appears to decrease potentially quite significantly the toxicities of these therapies. That's good for our patients. In many ways, not only do they suffer less, but they also may be able to be treated on an outpatient basis. And there are lots of advantages of that. In addition, it appears that the cells are less likely to become exhausted and to do their work in killing all of the cancer cells in a more consistent and prolonged way.
Dr. McGurk, what kind of success did you see in these clinical trials?
In patients with relapsed refractory acute lymphoblastic leukemia, where we would expect the 1-year survival to be about 10 to 15% and the 2-year survival to be in the single digits, about 5 to 7%. In that type of patient, we saw complete remissions of 63%. Now, we don't have a long-term follow-up. We do for some of the other CAR T constructs that I've mentioned out there that are looking very promising, and for many patients this has been curative therapy. And we are hopeful that the same will be true for Aucatzyl.
So the health system enrolled its first patient in CAR T-cell therapy back in 2015. We have treated now our 500th patient. This is video from the University of Kansas Cancer Center. You touched on it, but Dr. McGurk, just overall, who is a really good candidate for this latest CAR T?
This is a therapy, as I mentioned, for adults 18 years of age and greater. And any patient with relapsed acute lymphoblastic leukemia including those who have had a prior stem cell transplant in an attempt to cure their disease, are eligible for this therapy. It is an intensive therapy, and patients have to be relatively fit, and we look into all of those things, but there doesn't appear to be an upper age limit to these CAR T-cell therapies. We've treated patients very safely in their 70s and 80s with CAR T-cell therapy, as mentioned, for a variety of blood cancers, including acute lymphoblastic leukemia.
Dr. McGurk, always good to have you. Thanks for the science lesson this morning.
You betcha. Thank you so much.
Have a great weekend.
You too.
All right, it is a new option for stroke patients. The health system is offering a first in the region option for these survivors. It's called paired vagus nerve stimulation, or VNS. Joining us here in studio to discuss it is Dr. Colleen Lechtenberg, a stroke neurologist and the medical director of the University of Kansas Health System's Comprehensive Stroke Center. Dr. Lechtenberg, good to have you.
Thank you.
We're also joined by Dr. Sandra Billinger, the Vice President for the Stroke Translational Research. She's the chair. How are you?
Doing great. How are you doing?
Good to have you.
Thank you.
Across from me, Dr. Jeremy Peterson. He is an endovascular neurosurgeon. Doc, how are you?
I'm pretty good.
Thanks for being here to talk about this, because we're going to talk with one of our patients. Joining us virtually today is stroke survivor Tom Holt, his wife Karen, right there next to him. Thank you both for being here with us.
Thank you for having us.
Well, Tom is among several patients referred to the health system through area physical therapists. Once accepted for the implant, the first order of business in all of this is a baseline assessment. Here's Angie Racona with that story.
Obvious question here. Have you been diagnosed with a stroke?
Unfortunately, yes.
Tom Holt had a stroke 8 years ago. He recently took assessments that will serve as a benchmark.
What you'll do is try to push it away from you. Ready, set, go.
The test would be easy for most people. It's tough if you've had a stroke.
That's all I got.
You're smart, Alec. I love it.
Patients turn a key and pick up small items like a paper clip or pencil.
Our pencil is going to be at this line. Pick up the pencil.
Are you serious about this?
I at least want you to try. Okay?
I'm on it.
These exercises will be repeated months down the road to evaluate progress. It's called the Wolf Test.
I told him I didn't like his test. I'll send that to him.
Tom tries to complete tasks.
Are you able to bring it up to the box? Good job. Ooh.
Keep it up there.
Try again. Good, and then slowly come back down. Good job.
Most exercises are timed. The physical therapist takes careful notes. Some evaluate strength.
So I'm going to be measuring your grip strength. Squeeze, 1, 2, 3, relax.
Others focus on dexterity.
Ready, set, go.
The wolf guy doesn't have a sense of humor, or he does, I guess, huh?
Many exercises are simply impossible, something Tom acknowledges and openly challenges.
For now.
For now, exactly. That is the right attitude to have.
Tom, we appreciate your sense of humor and that we already have to bleep you at 8 o'clock in the morning. So we're taking it in stride. Because I know, how else do you approach it other than with some sense of humor? Because you've been living with these side effects of your stroke for the last 8 years. The test that we just saw you take, it was to see if you were eligible for this new VNS implant, and you are. So Tom, tell us why you agreed to have this implant.
Well, Jessica, I agree because I wanted to try to have some hope to get my arm back, so that test I can get the dexterity and maybe give hope to others that there is hope out there. There's some solution with technology to make things more manageable for stroke survivors, since there's so many of us around.
Sure. And hope, yeah, hope is key. Tom, what have doctors and your physical therapist told you about what to expect after the implant?
Well, most of them said it's going to be a lot of hard work, But there's hope that we can rewire the brain to get motion back in the hand. So we'll see what happens there.
Karen, I want to bring you in because you're the partner, the spouse. This is kind of a team effort. You work in tandem, I'm sure. So what are your thoughts about Tom moving forward with this implant?
Well, I'm pretty excited about this opportunity for him. I've watched him, kind of struggle and work in rehab over the last 8 years, and I think this could be a really good thing for him and us.
So Karen, you mentioned, just the struggles. If you could name something, what has been one of the biggest impacts on you and your family's lives since this stroke?
I would say probably one of the biggest changes for us would be we were such a spontaneous family before. We would just get up and see what the day brought us, and we'd go wherever and do whatever and didn't really have to think about, kind of what the place would look like. And now we have to kind of plan a little bit more about, is where we're going ADA friendly? Are there stairs? Things like that. Are the sidewalks straight? Are they got a lot of bumps in them? Which wheelchair we need to pack? That kind of thing. So I would say that's been one of the biggest changes for us.
Yeah, sure. It's things we all take for granted when we all just want to jump in the car and run and go do something. So thank you for sharing that. And beautiful family. Yeah. Thank you for sharing those photos with of your kids. Hang tight, where I want to talk and bring in our experts, but be sure to ask your questions. If you're watching at home, you can use the chat on YouTube or Facebook. You can also email the Medical News Network. That information is there on your screen. Dr. Lechtenberg, what makes Tom a really good candidate for this implant?
Well, he's a good candidate because he had an ischemic stroke and not a hemorrhagic stroke or a bleeding kind of stroke. He has upper extremity weakness. This is not FDA approved for lower extremity weakness. He's in the chronic phase of stroke, so that means his recovery has either slowed down or totally leveled off. And really importantly, he's willing to work really hard and do intensive therapy.
Go back to the two types of strokes. Explain the difference between the two.
So there's ischemic stroke where a blood vessel is blocked and then the surrounding tissue dies. And then there's the hemorrhagic stroke, which is a different category. That's when there's bleeding kind of into the substance of the brain. This device, as of now, is not approved for a hemorrhagic stroke, just ischemic stroke.
So Dr. Billinger, the implant itself is well known. We've heard of it before, but this is what the FDA is calling a new use. So what had it been used for, or is it currently else being used for?
Yeah, it's used in epilepsy and to treat depression, and so this is really exciting to move it into this chronic ischemic stroke phase.
Dr. Peterson, where are you going to implant that device?
So we basically always use the left side because the left vagal nerve has less communication to the heart, possibility for causing arrhythmias, things like that. Basically, that nerve runs right between your carotid artery and the jugular vein that both go through your neck. And so right in between there, you kind of dissect those off and then wrap this little kind of pigtail electrode around the nerve itself and then tunnel the system down to the battery pack, which is right under the clavicle, like most cardiac implants and everything that we put down in that area.
You make it sound so easy. All in a day for you. Sure. Is this considered minimally invasive?
Yeah, so it's an outpatient procedure. Compared to the other stuff we do, I would consider it less invasive for sure. But every surgery is a surgery.
Every surgery is a surgery, and certainly that's what a patient hears. So you got to walk them through what to expect there. Patients are referred by their physical therapist. So I want to bring in back you, Dr. Billinger, because we want to brag on you for a brief moment, if we may. You were recently highlighted in Women's World for reinventing the future of stroke recovery. It's kind of a big deal. The VNS, you're calling this kind of a new tool in the toolbox, an example of changing stroke recovery. Why is that? How is that?
Yes, it definitely is. We're very excited that, we're able to see these differences in people post-stroke. And so the exciting part is the research has shown that, you know, when you pair this vagal nerve stimulation with intensive rehabilitation, we see a lot of improvements in the upper extremity. And so what that really means for our audience at home is that they get to do the activities they want to do. They want to be spontaneous and hop in the car. You know, Tom had a hard time opening the can of soda or whatever that was to drink, and so they'll be able to do those things, potentially go out to dinner and feel comfortable with that, and hopefully plan less. But for me, the most exciting as a physical therapist is, you know, as Tom highlighted, it gives people hope. There's an opportunity for people who are living with chronic stroke, 5, 6, 8, even up to 20 years post-stroke. I've heard some anecdotal success stories from my colleagues where people are seeing these improvements and getting back to their lives and doing the things that they want to. And so that's a really exciting opportunity. So yes, I would definitely say this is one of those new tools in the toolbox.
And let's talk about the toolbox a little bit more, because and Dr. Lechtenberg, we had asked you earlier who's a good fit. I want to ask you as well, just to explain how it fits in the toolbox, kind of how it's enhancing the rehab, and that it's not just for somebody who's had a stroke.
Right. So typically when people have a stroke, they go through inpatient rehabilitation. Usually when they're in the hospital, they go through their therapy, their usual care. And then what happens is that people discharge home, and they may get outpatient therapy, they may get home health. But typically what I hear is that from patients is, I don't know what else to do or where to go. I've been told I'm plateaued, there's no opportunities to change. And so what this will do, when you pair the device, so that VNS system, with intensive rehabilitation and activities that are meaningful to patients that have upper extremity deficits, then they start to see that recovery. And so again, in that chronic phase, 6 months and on out, we start to see those improvements occur.
So there's no, you're not missing a window. Somebody could have had one 6 months ago or 20 years out.
Yeah, so far.
So that's good news.
That is great news.
Why though why is it for somebody who's had the chronic stroke versus just one stroke? How are the effects differently? Somebody has one stroke, they could have these continued lack of use of an extremity.
They can, yeah. So, you know, once somebody stabilizes with their chronic stroke, they're not making any more gains. They usually just settle into their life and think, this is where I'm at. And this device, and again, it has to be paired with therapy, because what the VNS system does, and Dr. Peterson, Dr. Lechtenberg jump in, but it stimulates the vagal nerve, which helps strengthen those connections when you pair it with the activity. It's stimulating that nerve and increasing these specific chemicals in the brain that are helping to strengthen those connections. And
Yeah,
I don't know.
I agree, yes.
And this is kind of showing us how it's working in tandem with rehab. Kind of walk us through a little bit about what it's doing and how it's prompting.
Yeah, so again, when they swipe the device and the patient, that vagal nerve stimulator is sending signals, electrical pulses, if you will, up to the brain. And so the really unique part of their pivotal study was that you can swipe that device and you might see a little bit of improvement, but what's really important is that you're pairing it with the activities meaningful to you. So again, if you can't move your shoulder, you may practice those shoulder movements. If you don't have hand movement, you're going to practice those movements, such as picking up a paper clip, picking up pennies, using a pen to write.
And when you say swipe, what do you mean by that? They're clicking something to give it to stimulate?
Yes, they have a little device, and it's about the size of, I think, as I said, as a pacemaker, and you're you know, swiping it or clicking it on and off, and when they do that, those electrical pulses go up. So we want to pair an activity with those stimulations.
So how soon after it's implanted and they start getting back into therapy with the implant, does a patient start to see any difference?
You know, that's a really important piece to this, is that some people, I've heard, because we haven't started yet, but I've heard from my colleagues around the country, some people make really rapid gains right away. And then some people actually have the slow and steady, if you will. They start to make gains, but the timing of that is a lot slower. And we don't really know exactly why some people are getting, better faster than others, and the recovery happens. And so I think that's where we want to, do research in the future to really understand that piece.
Dr. Lechtenberg, back to the type of stroke. Does it matter which side of the brain it happens on?
No, it doesn't matter. There's multiple areas of the brain that can cause weakness in an upper extremity, and it doesn't matter which one it is. The important thing is that the patient has upper extremity weakness, and there has to be some ability to move the extremity in order to benefit from the paired vagal nerve stimulator.
Dr. Peterson, we mentioned that this is it's not new, VNS, but it is new for what it's being used for now. So how do you make patients feel comfortable when you're explaining this to them? What are those conversations like? What questions do they have?
I think the big things are just what the day looks like when they come in, the plans for the surgery, where you're making incisions. Every incision hurts no matter what, so you're going to have some kind of pain you're dealing with locally that we take care of. Around the time of surgery, those are the big things. Obviously, any surgery you have to go over the risks and the potential things that can happen and what you do if you end up encountering those kind of issues. Infection is probably the big thing that you need to talk about, just because any foreign body that we implant into somebody has that risk for infection. And that can change if you have to take the device out or those sorts of things. So I think knowing those steps and what to expect ahead of time is the biggest thing. Obviously, we can't make predictions about anything, and I think everybody's brain is different. So that's the thing I counsel them is, we've done the studies that yes, it looks like overall there's a lot of benefit to this. There's really not a lot of other options from a surgery standpoint to get improvement. So my flip side is, it's a relatively less invasive procedure, but still a procedure, but it's the only thing we really have to offer at this point that's approved. And so I think that's very important for them to understand is, we don't know where their individual gains will be or how fast they will be. And it's something that we're going to try, but there's really not another option out there.
Right. Well, so and on that note, only option, and because we're the only hospital in the region to offer this currently, what's the demand like?
It's quite demanding. There's well, I think all three of us that are going to be doing the surgery part, our clinics are filling up with these quickly, and there's OR time and scheduling and getting an OR, and so there's a lot of scheduling up front, the making sure, depending on their insurance, everything, it's approved and all this stuff, so they're not stuck with a bill. Like, there's a lot of behind the scenes work. And over the last year, we've been trying to get this going, and there's been a lot of behind-the-scenes work. And so patients have known about this for a long time, and they're calling in, hey, I want to get this done, I need this. And it's like, all right, well, the good news is it's for chronic stroke. So if we do it this month or we do it in 3 months, it's not going to make a big difference, especially based on the study.
Again, that window doesn't close necessarily. Yeah. So, Dr. Lechtenberg, we don't want that to deter people, because there's so much stuff that they got to do behind the scenes. What should someone do if they're watching this and they think this might be something they'd like to talk with their physician about? Who do they go to? How do they get referred?
I think they can start with their primary care physician or their physical therapist to determine if they're eligible. And then from there are approved providers, therapists in the community that can screen the patient and see if they're eligible. And then from there, they get referred to neurosurgery clinic for a consultation.
I want to get to some questions from our viewers this morning. Jeremy wants to know, is the implant intended to be a temporary thing for a few years, just to speed up the rehab and recovery, get back to doing those things and functioning again?
So I think that's the part that we don't know, right? We have one clinical trial, but there's not like chronic data, right? 20 years out, are we using this all the time? So I counsel patients that we don't know if we'll have to change out that battery like we do on some stimulators, because I don't think we know if people continually use this throughout the rest of their life, if they continue to see some kind of improvements or benefit, or if it's that initial gains and then you kind of plateau again, and then there's no point to keep stimulating. Those are future things that I think we're going to be learning about.
Stuart wants to know if there's any time where that plateau typically happens.
Yeah, I think it's important to echo what Dr. Peterson said, and we just don't have the long-term studies, and so we're really fortunate to be following some of these people long term. We have a separate side study where we're going to follow people and do these assessments out to 5 years. So that way we can start to look at that. But I would say we don't know when they're going to plateau, but we're very hopeful and encouraged that, you know, again, we'll hopefully see these gains in recovery.
Lauren wants to know, do you know if this might eventually be something that you could do these rehab exercises at home paired with the VNS versus in physical therapy?
Yes, so it's important that we are continuing those activities at home. So the therapist is going to give you exercises to continue at home, so you shouldn't just be doing it in therapy, but when you're doing activities at home, and things that, again, your activities that are meaningful to you in your home environment, you want to do that.
So I saw the physical therapist, though, doing clicking and swiping. Is that something you can do at home? Or does...
The therapist, at this point, she was just timing him on the different tests, because we want to see how fast they can do.
Got it.
And if they get better. But yes, the person at home will be able to do the click or...
The click away,
yes.
Okay. Angie has a question. Karen and Tom, thanks for hanging with us. She says she can imagine that physical therapy can be frustrating. Do you ever feel that way? And if so, how do you both cope?
Yes, I feel therapy is very it's a big struggle, just because you know, I can't do the activities that look so easy to do. So I just have to stay positive, got faith, and I got a good support system that actually helps me keep going. And family and friends, you know, they give me strength to keep on the fight the good fight.
Karen, same question to you as the supporter.
You know, I watch him struggle, not being able to do things. It's pretty hard to watch, but one thing about Tom is that every time he goes into a therapy session, he works so hard, never complains, never or never says, no, I'm not going to do the exercise. He's just always very positive and very willing to work so hard.
Karen, for those watching your story, your family story, what do you want the big takeaway to be?
Well, I think that, you know, we're going into this kind of unknown, what kind of gains we're going to make. But, you know, I feel positive about it because Tom's just such a hard worker. And we have such a great village behind us, family, friends, our doctors. Everybody is supporting us so much. And I just am very excited about this.
Tom, what do you want people to take away from your personal story?
I want them to know that it's not the end to have a stroke. It's just another challenge in life. You just got to face it head on and stay positive and work hard.
And Tom,
good things will come.
Yes, they will. And we plan to keep following your story. So thank you for sharing it this morning. But we're going to see you soon in the operating room. Do you have an implant date set yet?
Yes, December 16.
All right. We will be there. We'll be there in the beginning and in the middle and at the end because we want to see how you're doing. And Karen, thank you so much for your time this morning.
Okay.
Thank you.
Thanks for having us.
Dr. Peterson, what do you want people to take away from this?
I think it's just that this community that we've built, not just at KU, but all of our surrounding facilities that have helped us with this project, are looking at ways to improve the care for these patients that we see every chance that we get. And so we're very early and very excited about being involved in these sorts of things and helping with our community and getting these patients here.
You're going to be busy.
It will be busy.
It'll be busy. Dr. Lechtenberg, what's the big takeaway?
I'd like to echo what Tom said about renewed hope. This device provides renewed hope for stroke survivors to improve upper extremity function in the chronic phase.
Dr. Billinger, what's the big takeaway?
Yeah, I like keep working, have hope, you know, and again, I think I'd like to echo what Dr. Peterson said, and that is, you know, we have had so many therapists in different hospitals calling to say, when are you going to be up and running in this? This is so exciting. We have so many patients. So I think there's excitement around Kansas City and this idea of stroke recovery.
Well, thank you for all your research that's
Thank you.
allowing our doctors to renew that hope in patients like Tom.
Thank you.
Thank you to all of our guests today. Thanks to our viewers for being here with us. Have a great weekend. We'll see you here on Monday. Coming up Monday on the Morning Medical Update, Chris Carlton wanted an expert to treat his prostate cancer, and he was willing to travel to find the best care. I'm Jessica Lovell on the next Morning Medical Update. The search that took Chris from rural Washington State to Kansas City, plus the difference he saw in a doctor who deals exclusively with prostate cancer. Monday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcasts. Now, everywhere podcasts are available.